Here at TCT, we are presenting our data on long-term outcomes of patients with large B-cell lymphoma treated with standard of care Axicabtagene Ciloleucel or axi-cel. These data are being presented on the behalf of a U.S. CAR-T lymphoma consortium. The real-world data from U.S. Lymphoma Consortium was presented at ASH in 2019 and later published in the Journal of Clinical Oncology. Here we showed that the outcomes of the patients who were treated with the standard of care axi-cel were very much in line and comparable to ZUMA-1 registrational trial. The study involved 275 real-world patients from 17 academic centers in the US. In this long-term follow-up, we report on the subsequent follow-up for the patients who were treated with standard of care axi-cel. The median follow-up for the study was 32.3 months. The overall survival at 3 years was 52%, which is very much in line and comparable to ZUMA-1 registrational trial, where overall survival at 3 years was 47%. The progression-free survival, the median progression-free survival was 9 months, and 3-year progression-free survival was 47.4%, which is very much in line and comparable to what was being reported for a registrational trial, ZUMA-1, of about 40% at 2 years. The predictors of long-term progression-free survival and overall survival were high LDH, poor performance status, ABC subtype, that basically portend for poor prognosis for both PFS and overall survival. There has been an emerging interest in understanding about long-term effect of CAR T-cell therapy, particularly cytopenias and secondary malignancies. In our study, at 1 year and 2 year mark, we observed about 10% grade 3 or more neutropenia in patients who get standard of care CAR T-cell therapy, axi-cel. At 1 year time point, that number was 10%, grade 3 or more neutropenia. At 2 and 3 year time point, it was also 10% in patients who had no relapse of their lymphoma, and they were just followed for a longer time. So it is an emerging problem, and we really don't understand the mechanism of this particular problem very well. Another area of interest is development of secondary malignant neoplasms after CAR T-cell therapy. In our data set of 275 patients, we observed 20 patients to develop secondary malignant neoplasm. So that's about 7.2%. About 8 of them were non-myeloid malignancies, like squamous cell carcinoma of the skin, sarcoma, endometrial carcinoma, mesothelioma, and angioimmunoblastic T-cell lymphoma. And about 12 of them, about basically 5%, were myeloid neoplasms, 10 MDS, 1 AML, and 1 CMML. The patients who developed therapy-related myeloid neoplasms were heavily pretreated, with median lines of prior therapy being 4, and about a third of the patients receiving more than 6 lines of therapy, and a third of the patients having a prior transplant. Time from axi-cel infusion to therapy-related myeloid neoplasm was about 30 months. So overall, we showed that the outcomes of patients who get standard of care CAR T-cell therapy, axi-cel, in real-world setting are very much in comparison with what was shown in the registrational trial ZUMA-1. We also show that there are a significant number of patients, 10%, who develop prolonged cytopenia after getting standard of care CAR T-cell therapy. Also of interest is this emergence of secondary myeloid neoplasms. We observed 5%, which is comparable to what is seen in other lymphoma long-term studies, but the true incidence is not is something that still needs to be established, and further follow-up is needed for that.